Bismillahirrahmanirrahim. Today we talk about the oral proliferative lesions. In the last video, I told you that for our convenience, we divide the lesions of the oral cavity, which is the entrance into the gastrointestinal tract, into the oral inflammatory lesions that include aphthous ulcers, commonly known as the canker sores, the viral infection by the herpes simplex, and the fungal infection by the oral candidiasis known as the oral thrush. The oral proliferative lesions are either non-neoplastic proliferations or neoplastic proliferations. The non-neoplastic proliferations include the fibrous proliferative lesions and the leukoplakia and erythroplakia. The neoplastic uh, the neoplastic proliferative lesions includes the most common of them is the squamous cell carcinoma of the oral cavity. Now, as I told you that the non-neoplastic proliferative lesions of the oral cavity include fibroma and pyogenic granuloma. Fibroma, as is clear from its name, it is a benign tumor of the fibrous tissue. Omas and fibromas, benign tumor of the fibrous tissue. And this tumor is derived from the fibrous connective tissue of the oral cavity, and it appears in the form of submucosal nodular fibrous tissue masses, and actually they result from connective tissue hyperplasia. And this type of hyperplasia in connective tissue occurs in response to some chronic irritation or trauma. The second proliferative non-neoplastic proliferative lesion is the pyogenic granuloma, and the pyogenic granuloma, as its name indicates, in granuloma it results from excessive formation of the granulation tissue, and it appears in the form of pedunculated vascular masses which may sometimes become ulcerated. And in addition to the proliferation of the fibrous tissue or proliferation of the fibroblasts, they synthesize collagen. In pyogenic granuloma there is also dense proliferation of the blood vessels. Again, pyogenic granuloma is formed in response to chronic irritation and trauma. For example, like chronic inflammatory conditions that occur in the oral cavity, and chronic irritation, for example, by ill-fitting dentures and other types of irritations like smoking. The pyogenic name is misnomer, and this is not a pyogenic granuloma which is caused by the bacteria like streptococci and staphylococci. It is simply an excessive growth of the granulation tissue that occurs in the oral cavity in response to trauma and chronic irritation in the form of smoking, ill-fitting dentures, using hard toothbrushes, and so many other conditions are there. Now in this picture we can see the gross and microscopic appearance of oral fibroma, benign tumor that arises from the fibrous tissue and that is caused by excessive proliferation of the fibroblasts that secrete collagen into the connective tissue portion of the oral cavity. The fibroblasts, when they are active, they are fibroblasts, but when they become quiescent and do not synthesize collagen, then they are known as the fibrocytes. And the fibroblasts synthesize the collagen that appears pink in the macroscopic slides. Grossly, the fibroma appears as elevated nodule having a smooth surface, and it may be firmly attached to the underlying mucosa, in which case we say it is sessile, but it may have formed a stalk, a root, and a bulk of the granulation tissue, and in that situation it hangs from the underlying mucosa, and we say that it is pedunculated. Under the microscope on the lower left side, you can see that there is excessive proliferation of the fibroblasts that synthesize large amounts of collagen, and the surface epithelium is stretched, and there is lot of collagen which is dispersed among the fibroblasts in the mass of the growth. The Fibroblasts having nuclei, they take hematoxylin stain during the tissue processing procedure and they appear blue under the microscope. While the collagen, which takes the eosine stain and which is pink colored, so the pink colored collagen, they appear pink, which are uh, dispersed among the blue colored fibroblasts. Now, fibroma is, as compared to pyogenic granuloma, it is uh, comparatively an avascular lesion. There are less blood vessels in fibroma, but in pyogenic granuloma, since there is excessive growth of the granulation tissue, so it contains lot of blood vessels. We recall that granulation tissue formation passes through stages. Number one is the stage of vascularization, in which lot of blood vessels along with fibroblasts and actively and functional fibroblasts, they are seen in the lesion. In the late stage uh, of the granulation tissue, which is known as the stage of devascularization, what happens that the small blood vessels present in the granulation tissue, they undergo atrophy, and here we mostly see the fibroblast and the collagen which is synthesized by the fibroblasts. So pyogenic granuloma is a tumor-like growth that occur in the oral mucosa, and it is a non-neoplastic lesion. There is no cancerous proliferation of the cells. It is a non-neoplastic lesion which is caused by an exaggerated formation of granulation tissue. Granulation tissue is also known fibrovascular tissue because it contains lot of blood vessels and fibroblasts. Now, this granulation tissue growth formation occurs in response to chronic irritation like smoking and other type of irritation, for example, ill-fitting dentures and trauma. The most common site for the pyogenic granuloma is the gingiva of the upper jaw, particularly in the maxillary region. And as we said that the pyogenic granuloma growth may be firmly attached to the underlying mucosa, or it may form a root or stalk and a bulk of mass which is hanging from the underlying oral mucosa, and in that case we call it as the pedunculated mass. Since it contains lot of blood vessels, so even if we touch it, it will start bleeding. And this is the reason that the pedunculated masses of the pyogenic granuloma, they bleed very easily. And why do they bleed? They contain lot of blood vessels. Pyogenic granuloma is most common in the first trimester of pregnancy, and most of the time it happens a sort of anxiety for the female pregnant, and she suspects that there may be some sort of neoplastic lesion in her oral cavity. But we know that after delivery, what happens that the pyogenic granuloma, it regresses. So we can say that there is some association of the pyogenic granuloma with the hormones that are having elevated levels in pregnancy, like estrogen and progesterone. Histologically, the pyogenic granuloma, it will appear under the microscope just as the granulation tissue in its vascularization stage, because there are a lot of small blood vessels and fibroblasts. But one thing here is important, that we must keep in mind various other diseases like, for example, cancerous conditions, squamous cell carcinoma of the oral cavity, when we see and when we examine such lesions. As we may do a mistake by uh, diagnosing a lesion as pyogenic granuloma while it may be a cancerous lesion. So it should be properly investigated. Now, the treatment of fibroma and pyogenic granuloma is surgical. Simply surgical excision and telling the patient that kindly avoid irritation and trauma in your oral cavity. For example, we can tell the patient to quit smoking, and to if he is using an ill-fitting dentures, we can advise the patient to consult the dentist and to make the dentures softly fitting in her mouth cavity. In this picture, you can see on the left side the fibroma, which is comparatively in a vascular mass. It is smooth, it is having smooth surface, and uh, this is in the form of an exopathic granule, which is on the uh, base of the buccal mucosa. On the right side, we can see pyogenic granuloma, which appears red due to its contain lot of blood vessels, and it appears as erythematous and hemorrhagic. And here I may tell you that sometime the pyogenic granuloma extends in between the teeth into the inside of the oral cavity. Now, after discussing the fibroma and pyogenic granuloma, we come to another condition known as leukoplakia, and its other its other type is the erythroplakia. So leukoplakia is really and actually a precancerous oral mucosal lesion. And when we say that a person is having leukoplakia in his or her oral cavity, we must suspect and we must work on it, and we must uh, do investigation, and we must observe the patient, because according to WHO classification, a white patch or plaque that cannot be scraped off, if suppose if there is oral candidiasis, which is a fungal infection and which causes the formation of a pseudomembranous proliferation over the tongue, when we take a tongue depressor, we can easily scrape the pseudomembranous exudate, and when we scrape it, we can see the underlying erythematous pink mucosa. But in leukoplakia, we cannot scrape the lesion. So any lesion that is firmly attached to the oral cavity, to the oral mucosa, and that cannot be scraped by using a tongue depressor or things like that, so we can say that it is leukoplakia. So the World Health Organization has a definition for it, and according to them, a white patch or plaque that cannot be scraped off and cannot be characterized clinically or pathologically as any other disease. The second part of the sentence is very important, because we should not consider a white plaque or patch as simply herpes infection, or simply is candidal infection, or simply any other inflammatory or infective lesions, unless and until we have proved it histologically. Right? Thus, until proved otherwise by means of histological evaluation, when we are sure that this is not leukoplakia, it is either lichen planus, which is an autoimmune condition. The white patch is either because of the tobacco smoking. It is keratosis and hyperkeratosis, in which the keratinized uh, uh, stratified squamous epithelium undergoes proliferation, and it is a form of hyperplasia. So if we can't label it as the lichen planus, or if we can't say that it is caused by smoking or tobacco, if we can't say that it is keratosis or hyperkeratosis, then we will label it as the leukoplakia. And leukoplakia is not as simple, because uh, leukoplakia, it is a precancerous condition, and why we are needed to exclude the other diseases, because these diseases, they also produce a lesion which is very similar to leukoplakia, and these diseases must be excluded before labeling the lesion as leukoplakia. And once we label it as the leukoplakia or erythroplakia, then we will deal this lesion as a precancerous condition. In this picture, you can see on the top left the lesion planus in the oral cavity, which is an immune mediated disorder, and that can produce similar lesion like leukoplakia. And the lesion planus also affect the skin. In the picture in the middle of the top, you can see the infected skin. And uh, sometimes psoriasis, which is an immune disease, can also produce similar pictures. And in the bottom uh, left, we can see the white patch that is produced by the smoking. In the middle of the lower center, uh, we see the pseudomembranous exudate, which is present over the tongue. And as I said, that this type of pseudomembrane can be easily scraped by using a tongue depressor, leaving behind erythematous area. And on the right side, in the upper part, we can see leukoplakia, which is a white patch. And we leukoplakia, if once we are sure that it is not any other disease and it is leukoplakia, then we will deal it as a precancerous lesion. When the leukoplakia contains large number of blood vessels, and if it is red and erythematous and uh, in appearance, and if it bleeds easily, then we say this is erythroplakia. And here we must note an important point, that erythroplakia is a more severe condition than leukoplakia, and transition to malignancy is more common in erythroplakia as compared to the leukoplakia. So coming to the conclusion, that the leukoplakia is a white patch, while the erythroplakia is a red valvulity plaque, because it contains a large number of blood vessels. And the common sites for leukoplakia are the tongue, the gums, and the lining of the mouth. And the diagnosis of leukoplakia is a diagnosis of exclusion. We must exclude other diseases like lesion planus, like smoking, the white patch which is found by smoking. We must exclude the oral candidiasis, which is a fungal infection, and we must exclude other diseases and lesions that produce similar plaques or patches in the mouth. So, if we have excluded all the other conditions and all the other diseases, then we can say that it is either leukoplakia or it is erythroplakia. And we must exclude candidiasis, keratosis, smoking, tobacco smoking, lesion planus, and other common lesions that can produce a similar type of lesion in the oral cavity. Now here we comes to a very important uh, point, that how leukoplakia and erythroplakia progress to cancer. And this progression is more rapid and severe in erythroplakia than in leukoplakia. First of all, what happens, that there occurs simple hyperplasia of the keratinized stratified squamous epithelium, and we use the term keratosis and hyperkeratosis, which is an overgrowth of the keratinized epithelium, and it is actually hyperplasia. And uh, now what happens, that in hyperplasia, what we see, that these stratified squamous epithelial cells and the keratinized oral mucosa, it appears exactly normal. Simply there is an increased number of cells, but the cells, they are morphologically very similar to the normal stratified squamous epithelium. But once we see that the cells are not normal, And there are some cells that appear morphologically not similar to the stratified squamous epithelial cells, but they have some morphological variation. They have some variation in their architecture. So we say that these are dysplastic cells. And here the important point that dysplasia is a type of adaptation, and adaptations is a reversible change. So the dysplasia can reverse back to the normal, and the cells that have undergone dysplasia, if they are in the mild or sometimes in the moderate form of dysplasia, and if the uh, stimulus or the irritation, if it is removed, these cells can turn back to the normal stratified squamous epithelial cells. But itself, dysplasia is a precancerous condition. But at this stage, it can be reversed by removing the uh, causes and triggers of trauma and irritation. Now, what is dysplasia? It is a dysfunctional cell growth, and slowly and gradually the morphology of the cell changes, and according to the change or according to the magnitude or amount of change in the morphology of the stratified squamous epithelium that turns into dysplastic cells, we stage the dysplasia as mild dysplasia, moderate dysplasia, and severe dysplasia. In mild dysplasia, most of the cells they appear quite normal. In moderate dysplasia, the number of cells that are morphologically dysplastic and different from the original stratified squamous epithelial cells, the number is increased. But coming to the severe dysplasia, we mean that most of the cells that have undergone dysplasia. And severe dysplasia is actually carcinoma in situ. By carcinoma in situ, we mean that the lesion is neoplastic, but it has still not invaded locally. There is no local invasion. But once the lesion invades locally, we will say it is the overt squamous cell carcinoma. So, losing the similarity to the original cells morphologically and appearing abnormal morphologically under the microscope are the cells that are called as the dysplastic cells. And the dysplasia may be in the form of mild, moderate, and severe. But once severe dysplasia has occurred, it will progress into the anaplasia. In anaplasia, there is total lack of structural and morphological variations. And we say that it is totally undifferentiated. When we examine under the microscope the mild dysplasia, we say that the cells are well differentiated. If they are moderately differentiated, we label it as the moderate dysplasia. But in severe dysplasia and in anaplasia, the cells are uh, lacking morphological similarity to the original stratified squamous epithelial cells totally, and there is a total lack of structural and morphological differentiation, and we say that the cells are very poorly differentiated, particularly in severe dysplasia. They are very poorly differentiated, and the next step is the anaplasia and the appearance of overt squamous cell carcinoma. Now, we conclude that there is a stepwise progression of the leukoplakia or erythroplakia to carcinoma. And this starts from keratosis, hyperkeratosis, mild, moderate, severe dysplasia, anaplasia, and overt carcinoma. But here clinically, it is important that as early as we recognize the lesion, the treatment is effective and successful. For example, if we recognize the lesion when there is mild dysplasia, we can treat it easily. But if we recognize the lesion when severe dysplasia has occurred, the treatment becomes difficult, and if we see the lesion that has undergone anaplasia and has invaded the local tissue, the treatment becomes difficult, and if metastases have occurred, then the treatment becomes more complicated and difficult and unsuccessful. So, leukoplakia includes a spectrum of histologic features which range from hyperkeratosis of the overlying a thickened but orderly mucosal lesions with marked dysplasia that sometimes merge with carcinoma in situ. The most severe dysplastic changes are associated with erythroplakia as compared to the leukoplakia. And here important is that more than 50% of those patients who develop uh, um, erythroplakia, in these patients, the erythroplakia will undergo malignant transformation into the squamous cell carcinoma of the oral cavity. With increasing dysplasia and anaplasia, what happens that in most of the cases there is some sort of chronic inflammation, and chronic inflammatory cell infiltrate can be seen in these lesions in the form of the chronic inflammatory cells like lymphocytes and macrophages. And the stepwise progression of the leukoplakia into the squamous cell carcinoma occurs through hyperplasia or hyperkeratosis, mild, moderate, severe dysplasia, anaplasia, and ultimately the squamous cell carcinoma. Now, coming to the neoplastic proliferative lesion of the oral cavity, we see that the squamous cell carcinoma of the oropharynx, we divide the pharynx into the nasopharynx, oropharynx, and laryngopharynx. And here we are dealing with the oropharynx. So 95% of the cancers of the oral cavity, they are squamous cell carcinoma. Right? Now, the small number of carcinomas known as adenocarcinoma, and as we know adenocarcinoma, carcinoma that occurs in glandular epithelium. And we know that what is the glandular epithelium in the oral cavity? These are the salivary glands. So they form a small portion of the oral malignant cancers in the form of adenocarcinoma. Now, unfortunately, the squamous carcinoma of the oral cavity, it is mostly diagnosed at an advanced stage. And as I said, that as much as this neoplastic lesion is in advanced stage, it will result in unsuccessful and treatment failure. Initially, it is seen that there are more than one tumors present in the oral cavity. And if it is diagnosed in that stage, when the tumors are in their initial phase, we can say that there may be a 5-year survival rate. Now, one characteristic of the oral squamous cell carcinoma is that before it metastasizes to removed organs, it causes local invasion, and it invades the surrounding local tissue. Now, the metastasis first occurs to the cervical lymph nodes, which are near to the oral cavity, and this we say that this is regional metastasis. And removed areas where the squamous cell carcinoma of the oral cavity metastasize uh, include the mediastinal lymph nodes and the lungs and liver. Now, what causes squamous cell carcinoma? The two important studied causes of the squamous cell carcinoma, number one is the smoking, tobacco. The carcinogens that are included in the tobacco smoke, they cause genetic mutations. And we know that cancer formation is the result of genetic mutations. The mitotic cell division in our body and in our cells, it is a strictly regulated and controlled process. And there are genes that regulate the cell cycle and mitotic cell divisions. Here we will particularly talk about those genes that are involved in the regulation, and those genes, they do not allow mutated cells with DNA damage and mutated DNA to divide, and they handle these damaged cells to the programmed cell death known as the apoptosis. But what happens that once these genes, which are known as the uh, proto-oncogenes, once they are mutated, now they are known as the oncogenes. And in relation to the squamous cell carcinoma, two genes are very important. One is known P53 tumor suppressor gene, which will suppress tumor formation, which will not allow mutated DNA, cells with mutated DNA to undergo mitotic cell division. And the other gene is P63, which is involved when the immature cells starts maturation to the mature squamous epithelial cells. Now, once these two genes are mutated, what will happen? That abnormal immature cells will be formed. There will be uncontrolled and unrestricted mitotic cell division. The lesion get an autonomy, which is known as tumor autonomy. Now it doesn't regulate the rules and regulations of the life of the cell cycle, and continually proliferate, resulting in the formation of the neoplastic cells and tumor. The other cause, which is commonly studied as a cause of the squamous cell carcinoma, is a virus known as the human papilloma virus. And here at this point, we recall that this human papilloma virus is the common cause of the female cervical cancer of the female cervix. And the human papilloma virus induced cervical cancer in the female, we have studied it. And if you recall the vaccine that is used for the human papilloma virus, and you recall the Pape-Nicolau smear known as the pap smear, which is routinely done in females from 21 to 65 years of age, to exclude the presence of any dysplastic cells. So the same human papilloma virus can be a cause of the squamous cell carcinoma in the oral cavity. And therefore, in some situations, if we use the human papilloma virus vaccine as we use them for females with human papilloma virus infection, we can save a substantial amount of people who are prone to the development of the squamous cell carcinoma of the oral cavity, the one that is caused by the human papilloma virus. So, human papilloma virus vaccine may be very beneficial for those patients. And as we saw that the squamous cell carcinoma of the oral cavity, it results from dysplastic precursor lesions, and these dysplastic precursor lesions are the leukoplakia and erythroplakia. Now, when we examine the stratified squamous cell carcinoma, for example, if we take a biopsy from the tissue, or if the tumor is removed and then it is cut into histopathology slides in the tissue processing procedure, we may get in some situations very well differentiated keratinizing stratified squamous epithelium, normal squamous epithelial cells with lot of keratins present. But in other situation, we may see highly deranged anaplastic lesions, and they are sometimes give the appearance of the sarcomatoid tumors. So here is a range of uh, uh, pictures and lesions that we can see in our histopathology laboratory under the microscope. We may see mild dysplasia, we may see moderate dysplasia, we may see severe dysplasia in which uh, there is marked disfiguration of the cells, and we may see anaplastic lesions in which there is total lack of differentiation, structural and functional differentiation. And in these cells, we can see the signs of the uh, neoplastic cells. For example, the uh, nucleus cytoplasmic and nuclear ratio may be uh, highly changed. Normally, if this ratio is 1 into 1, we may get a ratio of 1 into 6, because the nuclei in the neoplastic cells, they are enlarged and the cytoplasm is scant. So nuclear cytoplasm ratio may be changed, and uh, the nuclei are large and disfigured, and we see hyperchromatosis, and sometimes we may see mitotic figures, and all of these are the characteristics of the neoplastic uh, cancerous cells. Now, how human papilloma virus causes squamous cell carcinoma? We know that human papilloma virus is a virus, and the viruses are either DNA viruses or RNA viruses. And human papilloma virus, it is a DNA virus. It will infect the cell, it will get entered into the cell and into the cell nucleus, and here it will merge its DNA with the DNA of the host cell. And now it is using the DNA of the host cell for the production of viral proteins and for its replication. But the two proteins that are synthesized by the human papilloma virus are known as the E6 and E7. And what these two proteins do, that they suppress the tumor suppressor gene P53, which is a control and check, and which prevents cells with damaged DNA to undergo mitotic division in the G phase of the cell cycle. So once these genes are suppressed, what will happen, that cells with damaged DNA and cells with uh, mutated DNA, they will start undergoing mitotic cell division and resulting in the formation of uh, malignant cells. The cells with damaged DNA, when it is checked by the P53 gene, it is sent to the DNA repairing workshop. Once the DNA of the cell is repaired, it turns back, and if it is right, okay, it is allowed to undergo mitotic cell division. But if the damage in the DNA is so much that it cannot be repaired, then these cells, they are directed to undergo apoptic cell death. And this is a way these genes help in the prevention of the cancer formation. But once these genes are mutated, what will happen, that there will be uncontrolled cellular replication, and these cells, they will show severe resistance to the apoptic cell death. Under the microscope, since the squamous cell carcinoma or squamous cell carcinoma of the oral cavity, as we discussed that the squamous epithelial cells, it consists of the superficial keratinized epithelium, particularly present in the masticatory mucosa. So that is known as the keratinized mucosa, and that mucosa, the squamous epithelial cells in that mucosa contains lot of keratin, and keratin is a protein that makes the mucosa harsh, hot, and resistant. So it is particularly found in those areas of the mouth which are exposed to uh, hot food and uh, other uh, hard and solid objects. And comparatively, when we compare this masticatory mucosa in or this keratinized mucosa to the non-keratinized mucosa, which is a comparatively soft, smooth, and uh, not so much resistant as the keratinized mucosa. So what happens that in stratified in squamous cell carcinoma, these keratin proteins, they form whorled mosses, and they are known as the keratin pearls. And this is the very common characteristic of the squamous cell carcinoma that appears under the microscope. So a large number of these keratin pearls can be seen under the microscopes, and uh, the tumor cells, they form nests and islands uh, and are composed of malignant keratinocytes, and they are seen invading the underlying connective tissue stroma. Thank you.